Trials Director and Director of the Brain Nutrition Laboratory, the McCance Center for Brain Health. I typically moderate these sessions for our seminar series, but today we're fortunate to have Dr. Gregory Fourjon, who has agreed to introduce our speaker today. So I will step aside and introduce Dr. Gregory Fourjon. Welcome.
Thank you, Gene. Thanks very much. It's really a pleasure for me to introduce my friend and colleague, Dr. Zeina Chemali. She's director of neuropsychiatry clinics and education. She's medical director at McCance, and she's associate professor of psychiatry and neurology at HMS. Sadly for us, but a happy event for her, she has taken a position as vice chair of education at Cambridge Health Alliance. She'll work in the Department of Psychiatry in close collaboration with the Departments of Medicine and Neurology to oversee and revamp all of their educational activities. And those of you who know Zaina know that she is a superb, remarkable, unique educator. So at this stage in her career, is really a godsend, not only for her, but for all of those trainees she's going to be educating. I've known Zaina, who graduated from UAB, Lebanese Medical School, since 1999 when I accepted her into the consultation fellowship at the Brigham. Not a hard decision since she had already completed neurology and psychiatry residencies in the Harvard system. She went on to get her MPH at the School of Public Health. She's built services to manage complex cases that span neurology, psychiatry, and medicine. And then she's really done it through amazing culturally competent lens. She's worked throughout the Americas, obviously in the Middle East, and also in Africa. She created a neurology psychiatry residency program in Somaliland, of all places. In Ethiopia, she's trained doctors in Rwanda, Uganda, Sierra Leone, Liberia. And wherever she goes to teach neuropsychiatry, I get reports back, please send her again, send her again. It's just uncanny. It's remarkable. It really speaks to her great talent and her amazing knowledge base and her teaching ability. I really have never witnessed this kind of response. In addition, she's been a consultant for government entities, NGOs, international academic centers, and she places a great emphasis on early onset neurodegenerative disease and continues to see complex cases referred from all corners of the globe. She really believes in healthcare that surely involves treating very sick patients, but also needs to be supplemented by health promotion and illness prevention. And of course, the McCance Center for Brain Health is all about primary, secondary, and tertiary prevention. Um, she's the winner of the Anne Young Award for humane practice of neurology in our Department of Neurology. She's just made remarkable contributions wherever she's been in our system. And certainly that's true of her work at the McCann Center. She's going to be sorely missed in the departments of psychiatry and neurology. And I'll miss her personally. But thank goodness she'll remain a part of us in some capacity in the Pierce Division of Global Psychiatry. I'm happy about that. Now, I'm just going to two sentences from one of our best researcher clinicians, Joanne Campradon, who's the director of neuropsychiatry. And this is Joanne's comments about Zaina. Zaina is an incredible force of nature. She brought neuropsychiatry to MGH and single-handedly built difficult bridges across the Department of Neurology and Psychiatry with a dedication and generosity that melted away skepticism and preconceptions about what neurologists and psychiatrists could and could not do together. And then he ends up by saying, she has trained so many of us and has created a school of mentees that now live and work all over the country and the world, training new generations and expanding her reach while still consulting with her on difficult cases. The MGB and Harvard clinical neuroscience community owes so much to her vision and incredible dedication. I'm sure her mark will prevail for generations to come. Uh, I think that that really encapsulates who Zeina is and has been and will be in the future. So Zeina is going to talk to us about crisis as catalyst, opportunities to anchor through brain health. Zeina, thank you very much.
Yeah, thank you, everybody. Thank you, Greg, for this absolutely lovely introduction. And thank you for having me actually to close the academic year as I move to do other things. But I'm hoping I'm just next door. There is a bridge between us, maybe like 2-3 minutes away, biking and maybe 10 walking. So I hope to see many of you even more, maybe because we might have a bit more time. I want to, for today, I wanted to actually finish, if I may say, this academic year and part of what I have done in my career, because I have worked in many crises, and in the beginning they used to be more like war zones and or very vulnerable, very, very poor population, but then again worked through the COVID-19 pandemic here in the US. And so there is a denominator to all of those pandemic, as in, of course, they can be catastrophic and create a lot of inflammation everywhere in the body as well as in the brain. But at the end of it, I think there is always kind of like a silver lining towards what we could do in times of crises. And that, time and again, is to anchor ourselves through brain health one way or the other. So I am going to start by start first talking about brain health itself as a crisis, right? So and then we'll move on to the other crises. There is a crisis building in the United States because the Americans basically are aging, because life expectancy is getting longer, because the baby boomers are suddenly all going to retire. So not only that they are going to affect Social Security and other financial statements, they are going to come out of working, living longer, but with higher rates of non-communicable diseases. They are more likely to be obese, exercise less frequently, have hypertension and hypercholesterolemia. They could have already been diagnosed and treated for diabetes, suffered from heart attacks, and definitely consume way more alcohol than any other generation before them. And so having said that, you also have to keep in mind that non-communicable diseases, even though to the brain, they have the same trunk of causing neuroinflammation, the burden of these diseases is not shared equally. So people that are in lower socioeconomic background, they can't go outside in safe environment to exercise. They don't have enough green around them. They basically might eat more processed food than nutritious food. And of course, they have inconsistent, if not actually absent, preventative care. If we are talking brain health, so then we have one way or the other to talk to them about it in their context. If we're talking brain health, we have to talk about women's health, which barely is starting to pop up here and there. If we're talking about brain health, we need to engage also with people that have mental illness that basically will need a lot of brain health as well. So it is not only to a portion that can do it, is able to get the gluten-free, only vegetable, be in the park, run and stuff like that. We have to be as much as possible inclusive of everybody, including ethnic and racial minorities, because this is very important into everybody's health. So to anchor actually through brain health, I would like to start by defining what brain health is. So brain health has taken a significant traction in recent years. I mean, you go on TikTok, you go on pop culture, social media, there are people that are cashing money up the wazoo just to get you to live longer and have a healthy brain, and even, quote unquote, prevent dementia. So you have to be very careful, even though actually there is this idea of brain health. I think whatever you see out there on social media may not be the brain health we're talking about. So WHO defines brain health as the state of the brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains. So this is best, I think, away from that social pop culture to try to understand why we want to be as comprehensive as possible. The Lancet Commission came up with those modifiable risk factors for dementia that you are seeing in that picture on the right. And the whole idea is that when you are seeing people, when you are advocating for brain health, is to keep them in mind. Why? Because if we can change them even a little bit, we can alter the future of dementia in the people we are talking about. So please keep that in mind as we move forward. That also we know that the individuals that are at risk for dementia, and I've seen that time and again in the brain health clinic, it's not only their risk as family history, it's also what they can mitigate for or against within the environment and social and economic factors. So if all of them are bad, you can understand, I mean, there is no way out. But if actually you are able to work on brain health, you can in some way mitigate that genetic load that you already have. So it's not a done deal. Things could be done to mitigate neuroinflammation, to keep that brain quiet and not basically get going with dementia. And at the McCance Center for Brain Health, we have started, I mean, it's a long journey. We started with the Brain Care Index that was over 10 points, and then we moved through the ideal brain index, and then we felt that ideal is too biased, and what if, I mean, it's also too stigmatizing, and then we moved to brain care score and expanded it to be not only just for 10 points, but points over physical, lifestyle, as well as social and emotional elements, and that we scored it over 21. As I am actually also telling you that there is the Brain Care Score 2.0 that has undergone a Delphi process that now will be on a different scale as well, but keeping the core of the physical, lifestyle, and social emotional. People who have read like manuscripts and papers lately, even in the New York Times, that Brain Care Score with the 18 modifiable risk factors has also made very major headway with Dr. Singh and the team working with her to basically move those forward and try to understand what it is that can affect and what it is that we can modify around that. So shifting a little bit, because is the context where I also work, and taking into what I've already told you. So when you work with very vulnerable population, and I mean example, the Syrian refugees in Lebanese refugee camps, those are people that, I mean, the food is whatever you get for the day. Of course, UNHCR does not cover chronic illness, will definitely not cover medication for diabetes or high blood pressure. When they ran away, they could not basically pick up those medication with them either. And they are now in exile. They are afraid of dying. Where would they be buried? Their ancestry is someplace else. All of that is there. And yet, I mean, you're seeing them. There is a high level of depression, the cognitive disorder tracking to depression. And you're telling yourself, this is definitely that trunk that is going to give all of those people a lot of neuroinflammation that is very much trauma-based. But this is not only in other places, right? We have been in America through COVID, through how people defined COVID and the long COVID, how those things that are sometimes perceived as major by some population are not by others because something else preceded that, and maybe others have already been through so many crises that one more does not make any major effect. But this is something to keep in mind. We are living it every day. You can go to places where now you're taking care of trainees, of faculty that you are there basically to train them, but now they have a compounded traumatic experience, not only COVID, not only a major blast, not only the financial crisis, etc., etc. And yet they are there trying to deal with patients themselves when they need a lot of help. So thinking about all of those things that we can go through in life is the way to think about how can we anchor it to brain health in times of crises. So if whatever I have told you, you're saying to yourself, oh my God, we're living in a brain health crisis. Here people are getting older. In other places of the world, there is like one catastrophe after the other. You guys have something that you have started, which is the brain care score. Other people also have done it. How come still brain care health and is not unanimously embraced? And I think having worked through that for years and continued to, I think the challenges are really in the implementation. And this actually says it, because when we are implementing brain health, when we are taking care of everybody, so it's brain health for all, it's brain care score for all, we have to understand that all of us are broken somewhere, somehow. There is this factor. So, but we can still all color the same. So if you can convey that message to whoever you are talking to, whether it's a patient, whether it's a caregiver, whether it is you're doing population health with refugees or elderlies or pediatric population, all of that is to basically get them to be motivated and understand they can trust you to move on, adding one element towards their brain health if they can. I would like to think about implementation at different layers, and this is a little bit my public health speaking. So there is the patient layer, there is the caregiver layer, because anything non-communicable diseases is a system disease. There is no way it's one person. So it's the person and the family and the community. There is the provider level, and whether this is a primary care physician or specialist. Then there is the system level. And then, of course, there is the policy level that we need to address. So the patients feel very stigmatized, right? So if they've had a stroke and you're seeing them post-stroke and they barely can come up with 2 words, they feel less of a person. If a younger adult with multiple sclerosis and depression will feel less of a person. A patient that you are seeing after a traumatic brain injury, they come to you with already loaded with, we are not the way we used to be, even if that used to be is not their very best, but they feel that people look at them differently, people scrutinize them differently. And on top of that, in the US, people live alone and they feel very isolated. So they are thinking about all of that. So you need to keep that in mind when you're seeing those patients. You need to keep in mind where they are coming from. If they are in Navajo Nation, your discussion around brain health is going to be very different than if you are seeing a patient at MGH. There is no way about it. The patient at MGH, if their HbA1c is around 7, you basically sound the alarm. Everybody is on top of the patient, already seeing so many specialists. In Navajo Nation, people are basically baseline is in HbA1c around 10. If they are below 10, people actually celebrate. So you have to keep that in mind, because at the end, you want to invite everybody to take care of their brain health with where they are at, and yet what they can do better to get better brain health. At the caregiver level, I don't want to preach to this community that the caregiver sometimes is as sick as the patient. So they are there all the time. They're doing everything for the patient. At the same time, if we want to talk about cultures, there are some cultures where there is intergenerational families that cohabitate. And as much as this might be a hindrance towards privacy, actually it has some sense, because then you have the younger generation being in the same household taking care of the older generation. Here, because of more this like smaller circle of family, the person, often a woman, actually ends up doing it on her own, either to a husband or to a parent, or sometimes even to their own children. And so the Alzheimer Association did a survey and tried to explain how much of that is a burden on caregiver. Is often they end up quitting their job because it's very hard for them to continue. They will arrive late to work. They have to leave early. They basically don't show up to work often. There is a lot of money that the families will ditch on their own because there is no safety net to help do all of that. So they have to navigate this very complex medical and behavioral and social challenges on their own as well. Having said that, caregiving is not perceived the same everywhere in the world, right? So white caregivers might experience it even worse because they experience it as a hostage situation, while others perceive it as a journey, and they are all together in that journey doing it. They don't carry on that huge load of hostage situation. I have to say, though, that perhaps the other cultures live a more simple life, so they are both out there together in the farm. They are doing together kind of the basic stuff that they do every day. Cooking becomes even much simpler than when it is here, so keep that in mind as well. And in some places, as I said, there is family harmony around caregiving. I mean, you can imagine how much family disruption and disharmony can give to caregiving, and how sometimes there is a lot of bickering. But in some places where caring, for example, for the oldest is a responsibility and something that they have to do, it is duty, people get trained from very early on at doing it one way or the other. Another layer is the provider layer. And here we have like really two forks. The specialists, and we don't have enough of them. And if you live in rural America, just forget about it. Few weeks ago, someone gave grand rounds on rural neurology, and basically in the Washington, Seattle area. And it was mind-blowing, but I'm sure it's the same everywhere in rural America. And there is no specialist. So you do just with what you have. There is no specialist for dementia. There is no specialist to start picking up mild cognitive impairment to get them to the treatment they need maybe ahead of time. People that are of basically Indian descent, Alaska Native, Hispanic, they have to travel for like 2 to 4 times longer to see a brain specialist than basically their urban counterparts. So people walk everywhere or just travel for hours everywhere, not only in the African continent, to access care. So just keep that in mind too. So the primary care physicians are saying, okay, there isn't enough specialists, then everybody is now coming to see us. Everything is on us. We are not trained to do that. Because they're not trained to do that, then they order a lot of tests, especially if they don't have resources. Their time with the patient is very short. They don't get paid enough. They lack support staff. They can't work with other people to implement also multidisciplinary. So they become the scapegoat of the system, which should not be there. I mean, the system should, in one way or the other, be able to embrace everybody, so we help each other to come out of crises and to implement brain health stronger. Because we could talk as much as we want. If we do not put things we talk about as implementation, it won't get us anywhere. So, and now after the system basically has let a lot of people down, the patients, the caregiver, the primary care physicians, the specialty doctors, the services are like abysmal. The pandemic, whatever we had, we completely also lost. Then come policy. So it's as if we haven't done anything bad enough. Then we have policies that, of course, they need a lot of reforms, but it might be that we wake up one day and those Medicare and Medicaid services are no longer there. But we need to take care of those patients. I mean, they're not going anywhere. We need to take care of those caregivers and the families. They're not going anywhere. The primary care physicians are not going to suddenly have so many resources to work on. And also the policies are affecting a lot of people in their training. Who trains? What are the numbers of the trainees that we can send to help our population? For the international population, there is now this new reckoning that the aid is cut. At the same time, the world probably is the most unsafe for now decades that has been before. And so it is becoming even more problematic. There is some stuff that is starting to emerge, and I'm hoping that they will actually move to meet the needs, even though the needs are very fragmented. But for example, Medicare has put in an annual wellness visit into which actually you could do a cognitive assessment. You have more time for it. You could bill for it as well. But actually, it is underutilized. So even though it is there, people are not utilizing it. There is the Dementia Friends program, and also the WHO put forth an elder-friendly city. Some cities have picked up on it. Boston is one of them. Other cities have not, because for them it's not a priority, even though it should be. So I as a public health person, I can't only tell you what are the challenges and talk negatively about them without proposing solutions, right? The whole idea is, what can we do? And what can we do is basically to understand that we need to address the implementation at the level of a patient by inviting them, by being very motivational, by understanding that enhancing behavioral change is the most difficult thing. You could tell somebody that eating 5 cookies is not good for you, but for them, and they understand it fully, but for them to basically shift from not eating 5 cookies to maybe eating 1 or 2 will take a lot of time if actually they engage in it. So you have to be with the patient, with whoever you're talking to, at that level to see how they can modify this behavioral change. And again, telling them, empowering them that brain health is within their own reach. We spend hours when we see our patients at the McCance Center for Brain Health in the preventative clinic to basically just tell them, we hear you, we want to help you, just pick one element that you can work on from that list, and we are there for you all the way. And when you finish that element, we can tackle another one. You have to understand also their context and the culture that they live in, and let it be organic, not imposed. Imposed does not get you anywhere. It does not. But basically trying to meet people in Navajo Nation that understand that maybe they need to walk, but they are more motivated to walk if they that is a true example. Wear something yellow because yellow means the sun and yellow is power. Then you get them to wear yellow. And this is what happened in their diabetes program. They basically gave people white T-shirts, and this is how they got a buy-in from the patients to do their walking. And at the end of the walk, they will give them something yellow, which in their case is corn. So this is very important. Those are lessons learned to basically get people to feel better and hence have a better brain. So in the caregiver, I mean, the Alzheimer's Association has done few things, let's say through the REACH program. There are other big disorders that have also very, very good outreach to caregivers, but we can also tell caregivers actually and or engage them that caregiving can also be positive. It's a personal accomplishment. You would enhance family cohesion. You would have a renewed sense of purpose in life. And actually, there is something good to that caregiver care recipient relationship. They will rediscover it. It's not all that negative. And actually, if they turn a little bit onto that reward, personal reward to them, they might actually see some good thing out of it and not only the hostage situation. Engage with them. When they come with a patient, not only talk to the patient, talk to them, because they at times could be as sick as the patient. Allow them to give permission to themselves to take time for brain health. So this is very important. Tell them to go see their own doctors, that it's not only about the patient that is sick, but it is about themselves as well. And then, how do you engage primary care physicians? You're going to tell them you are the key to everything. The patients, the family trust you. You know their secrets from so many years. You are it. Without you, we cannot do anything. But here are things that we can do to help you out. So we can help you out by getting you to communicate with others, train better, get multidisciplinary basically care, have the communities open up for healthcare workers, get social worker on board. You don't need to do that all by your own, but really empower them that they are the most important key link in that chain. It's not the specialist. It is not. The patient trusts them. You trust them. And actually, they are called 10,000 times more on a problem than actually you as a specialist are taking care of. So you have to respect how they are living and the challenges that they are going through. And with that, actually, you are going to let the system do its job. Advocating for it, campaigning for it, talking loudly about it, do anything you can within your own circle to explain to the system that better brain health is better health for all. People have different needs. We could work as a public health measure to get better brain health for everybody. Of course, we could leverage virtual care. Of course, we can go on Zoom, but just make sure you have community health workers that can be there at that home to get the Zoom going, rather than think that that person that has so many things in their brain already are going to be knowledgeable of what to do. And if by, oh my God, they don't show up on that Zoom, then you cancel their appointment. They cannot be rebooked into the system, when actually it's not that they did not want to, they basically didn't know how to do it. Work on interventions that actually can give you some immediate results, all right, as you think long-term about what can happen later as well. And then there are nations that actually understood that. Finland, for example, or even Japan, they understand that brain health is much better for everybody in the system, and actually will also get the government to not use a lot of money to only take care of dementia, but actually to prevent it. And they have national programs about brain health. So there is the Finnish national program about brain health for the whole nation, since they are babies up to like when they are elders. And in Japan, for example, there is this holistic approach and community engagement as an integration and key to success. So they try to move with the elders where they are at, but get them to engage and feel meaningful into the society at any age that is. So just before I end, I really would like to go back to those places that maybe not a lot of you know about, but where the places where there is nothing anymore, right? So they have nothing. And even then, I think our duty is when we deal with those populations that have nothing anymore or lost everything, to anchor them around brain health. How do you do that? They have this innate survivor strength and the meaning of life. And I have seen it not only in war zones, I have also seen it, for example, here in America and Navajo Nation. When if you do their brain care score and you want to calculate it, they probably will take 1 point, which is the meaning of life. So you basically work on anchoring around this meaning of life that becomes for them the message of their survival. They also know that they are going through in a atrocious situation, but all together as a community, sharing that same experiences and talking about them, even if they are living in hell, makes it actually feel good for them. And they can always have time still to connect and maybe exercise by they will have to do it because they have to build up tents. They have to basically go very far away to fetch water, to fetch food. All of that, you build it into exercise rather than them going just to the gym to do it. They learn to pace themselves and practice mindfulness because there is nothing else for them to do, right? They have to accept one way or the other that they have lost a lot. And then if they are caring for other people, which they often do, and sometimes the grandpa is caring is caring for the grandchildren because actually mom and dad have died, there is like they are joyful into that responsibility because their grandchildren are still alive. On the right hand side is a picture, actually one of the people I've seen on the refugee camp drew that for me to give it to me before we left. And this is for him. I mean, see, the person is actually in a wheelchair, but at the same time, and he writes in Arabic that despite the pain, there is hope. And in Arabic, actually, same as you just permutate between the letters and you get from pain, which is alam, to hope, which is amal. And that says it all, right? So one way or the other, they are able to find that hope by accepting what is happening. So as a future direction, I think advocacy to highlight the urgency of the situation of the brain health crisis is there. We need to advocate for brain health for all and at all ages. That means women health, rural health, psychiatric population health, vulnerable population health, you name it. To basically integrate culture as your friend and not a foe, because if you know what the culture is about, you can actually get where you want. To get people to learn from each other, maybe we need to learn more from the Finnish people and the Japanese and others, and perhaps even people learning in refugee camp as in how to leverage that crisis. And because we are in 2025, and because probably the future from here on cannot exist without AI, I would like to advocate for AI, but also AI for all. And maybe not only AI, but AI companionship that can help keeping the motivation going and the behavioral changes, perhaps, that can facilitate the connection and the care coordination in AI, in dementia care, in stroke, in depression, in anywhere you want, basically, and everywhere we can put it in. And with that, I'm going